This video lecture is going to cover eating disorders and substance abuse disorders, which can, in some instances, overlap quite a bit. As we take a look at eating disorders, we're taking a look at an imbalance in caloric intake. Now, I'm not talking about the metabolic nutritional aspect of the disease. We covered that earlier this semester when we looked at things like marasmus and kwashiorkor. We're talking more about, the mental, the psychological element that causes you to have an imbalance in the amount of caloric intake. And so we can talk about if your hypothalamus, remember which that controls your satiety center, your hunger center. This is the one that controls your appetite. And so we find that a lot of people with imbalanced eating disorders may have a neurochemical imbalance. And so using special medications may help to reset that. It could be purely psychological. We find that some people find they make an association of consuming a certain food with a certain emotional state or ignoring a certain food with a certain emotional state. And so it could be that neurochemically they're fine, but there may be an emotional psychological element that is preventing them from wanting to eat or wanting to eat too much of a certain object or too much. And so as an example, we talk about someone who suffers anorexia nervosa. Anorexia nervosa, as it says, is starvation behavior. This is a person who simply does not consume enough calories. And I mean, this can be due to a variety of emotional, psychological, hypothalamic events, but for whatever reason, they simply are not consuming enough nutrients. And so they could wind up having decreased bone mass, they could have anemia, they could develop cardiac problems, blood pressure problems, dehydration issues if they're not getting enough water with their food. And so there are a lot of physical elements that can come into play with this, but it all boils down to they simply are not consuming enough food. Compare that to bulimia nervosa. Now, this is what we call binge and purge. This is the person will consume excessively, and then they want to purge it from the body before the digestive system gets a chance to process it, either by inducing vomiting or by taking laxatives, causing it to shoot through. So they're consuming enough, which satisfies that hunger center of the brain, and now they're no longer hungry. But they then purge themselves before it gets into their body, into their bloodstream, into their tissues. And so you can imagine, again, this is going to cause a lot of physical problems. Someone with this is going to wind up, if they're causing vomiting all the time, that's going to cause acid reflux, damage the esophagus. The acid is going to burn up through the pharynx. It's going to damage the enamel of their teeth. If they're taking laxatives all the time, that's going to damage the sphincters down the rectum, could cause problems in the colon, not to mention, obviously, the malnutrition and all those effects. And so there are a lot of physical things that can result from either anorexia nervosa or bulimia nervosa. Compulsive eating disorders where a person eats beyond being full. And so this is very commonly due to a neurochemical issue or sometimes an emotional issue. As I said, someone may have a connection to the fact that, I can either consume food, which makes me feel better, or sometimes the food distracts them from feeling bad. And so they will eat and eat and eat to the point of eating beyond what their body needs. Maybe a neurochemical event where they just, I'm eating, I'm still hungry, for God's sakes. And so that's where the compulsivity may come into it. Now that's our eating disorders. And so that's simply the imbalance in the caloric intake. A similar concept is substance abuse disorder. And this is where you overuse a mood-altering substance. And you could consider some of our eating disorders as substance abuse disorders. Our mood can be affected by what we eat. And so if you're doing the compulsive eating disorder, that could be an example of this. This can also be dealing with, and so this can also be dealing with addictions. Addiction is when you continually use a mood-altering substance or behavior despite adverse consequences. You know it's bad for you and you keep doing it. That's an addiction. And so an addiction is doing something that you know is bad for you and not stopping. And so when someone becomes addicted to something, they know it's not good for them. Now, a physical addiction is where we find that your neurochemical pathways actually change their tolerance levels in response to that constant stimulus. I'll throw out an example, caffeine. If you suck so much caffeine every day that when you suddenly go cold turkey for a couple of days, and your neurons are so used to so much of that caffeine stimulation that suddenly lacking it causes them to send feedback signals back to the brain, you get this just monster headache, and to the point that you just simply can't process anything. You're going through thought blocking again, and it's just going to cause such headache and such sleep disorder and such eating disorder, and until the neurochemistry resets, it's going to make you non-functional for a period of time. That's an example of a physical addiction. Psychological addiction is there is no change in neurochemistry with addiction. There is no tolerance change. You may decide, I like caffeine, so I drink caffeine. I like caffeine, I drink caffeine. I like caffeine, I drink caffeine. And as you drink it down. And when you go without caffeine for a day, the neurons are fine with that. But someone may decide, yeah, but I just enjoy it so much that, I'm going to convince myself that I just don't feel good without it. So I'm going to order another coffee. And so that would be a psychological addiction. Um, the tricky part of dealing with addictions with patients is I can't tell you which are physical, which are psychological, because it varies from person to person. Some people may have a physical addiction to alcohol. Some people may just have a psychological addiction. Some people may have a physical addiction to Vicodin. Some people it may be psychological. Some people chocolate. Some people sugar. Some people caffeine. So and so we have to treat all addictions as physical until we know otherwise. Because if you run someone cold turkey, removing all that stimulus from a psychological addiction, they may not be happy, but they will get through it without any neurologic damage. If you have someone who is physically addicted and you take them through cold turkey, they may have a psychological break because they may have a neurochemical reaction. Hell, may have a seizure, may go into a seizure. And so that's why you've always got to treat an addiction as physical until you know it's not. And so you got to be safe on the patient's behalf. I told you about tolerance. Tolerance was that decreased sensitivity. The idea that your neurons need more of the stimulus to get the same effect. First time you drank a cup of coffee, you took a sip, oh my God. And it was so potent that just, oh wow, I'm on a buzz. You've been drinking coffee now for a couple of years that you take a quad espresso just to kind of get a taste for it. And so you develop that tolerance and buildup. Withdrawal effects. And so we take someone cold turkey. When they go cold turkey and they have those withdrawal effects, that's where the neurons try to kind of reset themselves after having had that high level of stimulus. And psychological addictions, they may demonstrate some withdrawal effects just emotionally and just not having fun. It's the psychological withdrawal effects that we got to be careful of. Those are the DTs. And DTs are basically when a person has a severe form of delirium when they're going through a physical withdrawal from a stimulus. It could be alcohol, it could be drugs, it could be whatever. And to the point that as the neurons try to reset themselves from a tolerance back to a normal threshold level, some of the neurons may fire inappropriately and they'll have abnormal sensations. That's where you get, I feel the ants all over my skin. Oh my God, they're all over me. My skin's on fire. Oh my God. And so that's where they're going to that delirium tremens. And so they're having that abnormal sensations, that more abnormal perceptions. They get that incredibly psychotic paranoia, and they just suddenly are just violent and agitated to the point that it's just the neurons are misfiring to the brain is not thinking clearly. So that's why, like I said, you got to be careful about physical versus psychological. We'd like to try and we'd like to avoid the DTs if we can. Sometimes you got to work your way through it, but you got to be careful that the patient does not get injured during the DTs. All right, that takes us through our eating disorders and our substance abuse disorders. Not a huge pair of topics, but an important pair. So take your time reading through this stuff, watch the videos, and let me know if you have any questions. Good luck.